Okay. So good evening, friends. Welcome to this Tuesday evening academic sessions from Yashoda Group of Hospitals and Department of Critical Care Medicine. So we have been doing a series of webinars on extracorporeal therapies after that proud moment for all of us in Yashoda Group of Hospitals that we got recognized as one of the very few Platinum Center of Excellence in the ELSO. So last week, me and Dr. Charan were there in Washington, D.C. to receive that prestigious recognition. So we have been thankful to all our well-wishers, colleagues, friends, seniors in guiding us to reach there. So in the process of this, we have been conducting this series of extracorporeal webinars. And this was one of the, I think, interesting area of extracorporeal therapy. Maybe a decade back when we were talking about extracorporeal therapy, we were all believing that whenever a patient is on such a large cannulas, or a VV or a VA, need to be sedated, paralyzed, and probably need to be restrained. But over a time, we could realize that these patients can be off relaxant, can be off sedation, sometimes can be extubated, sometimes maybe on a track on a thermovent. And some of these patients in recent times, we have seen have been pulled out of the ventilator and been walking. So these are all the changes which we have seen in the last decade. And the Awake ECMO, patients on ECMO who have been doing physiotherapies, aggressive rehabilitation to keep their muscle mass intact, their physical reserve intact, has been a new norm in all those patients who have been actually transienting or waiting for a transplant or a bridging for a transplant. Other than that, also, we have seen some cases where any form of invasive ventilation may not have any great help, something like a very bad fibrotic ILD lung or a very bad damaged ARDS, paraquat poisoning lung. The HFNC has played a major role to actually help us in this air hunger. So all these patients where we could actually extubate to HFNC, or we initiated HFNC, and then if the patient ended up to that stage where they need some form of extracorporeal therapy to support their oxygenation, we put them on Awake ECMO just by giving a local anesthesia. So I felt the role of HFNC has been expanding over the last maybe few years, from a hypoxemic respiratory failure from that FLORALI trial in 2018. Now it has been expanding slowly to in different areas, including post-extubation oxygen therapy, maybe in areas where now we are talking about a procedural apneic oxygenation, pre-intubation, maybe pre-oxygenation by apneic modalities. And the other was this Awake ECMO, where we actually try to counter the air hunger by putting some amount of HFNC to make them comfortable. So bring that area, we thought of actually having two parts of that: the expandable or expanding role of HFNC in the last decade or so. We have Dr. Kaladhar, who is HOD and senior consultant in the Department of Critical Care Medicine. He was talking about this HFNC in the recent congress of one of his conferences. So I felt it was a very good actually presentation to bring into this kind of forum. So I request Dr. Kaladhar to bring that. So he will be talking on that, and followed by as usual, our ECMO clinician and our consultant in the Department of Critical Care, Dr. Sricharan, will take us through how this HFNC played a role in bringing this Awake ECMO as a reality in some of our patients. So this is the combination. And after that, we have an expert, Dr. Arpan Chakraborty, who has a vast experience in the field of extracorporeal therapy. So we will take his expert opinion on different questions related to this. So to begin with, I request Dr. Kaladhar to actually take us through the HFNC, different spectrum and expanded indications of HFNC, and then we will go to the next talk. Over to you, Dr. Kaladhar.
Okay, sir. Good evening, friends. Thank you very much, sir, Venkat sir, for that introduction. I think we feel privileged and proud to get that award from ELSO, the Platinum Award. Very few centers in the world got. Thank you, Venkat sir, for leading us to that level. And with that introduction, I will be talking about the overview of the HFNC and the support. What is it actually, how it works, and the general indications. Basically, I will stage the background upon which Dr. Sricharan is going to talk specifically on Awake ECMO, especially from HFNC point of view in Awake ECMO patients, how it is going to work. And probably then the experts panelist and Venkat sir moderation will bring further deep dive into this topic. So with that, I will go forward. As everybody know, the flow nasal cannula near to 10 years, I think it's come into very good picture. Like most of the times, especially during COVID-19 wave, also most of the people were using it. But of course, there was a bit oxygen scarcity because of which there was we need a lot of flows. Other than that, I think it has given a very good, definitely in some cases, outcomes. So, with that background, so flow nasal cannula, what is it actually speaking? If you look at in this picture here, so there will be a gas source where the oxygen being connected, the flow will be set here, and pressure relief valve will be there, which will be depending upon this pressure relief valve, the flow will be determined. It may go up to 60 liters per minute flow. And a very good component of this machine is heated humidifier. So as you compare to NIV, a non-invasive ventilation, the humidification most of the times is the problem. So especially the patients who are put on ventilator NIV, the humidification, we do put heated humidification. Other than that, if we put HME, that's not a good humidification. But here it's a very good. And there is a nasal interface. It's like any nasal cannula, like the regular conventional nasal cannula. It's a bit more, but it is softer and is very well tolerated. So this is how the machine looks like. So what happens exactly? The HFNC has four elements, as I was telling: flow and the oxygen source and heated humidification. These are the components which play a very crucial role. So because of very high flow, so it decreases the upper airway dead space, like as we do generally transtracheal air insufflation, where rapid insufflation leads to decreased airway dead space. So the high flow, whatever the dead space is being there in the nasopharynx to laryngopharynx, will be decreased, because of which the oxygenation improves very well. And I will discuss further other mechanisms also. If you look at in this picture, very beautiful picture here, very Goliger et al. In AJRCCM, it is been published in 2007, described the various effects of HFNC support. If you look at the five mechanisms here, so one is heated humidification of inhaled gas, washout of upper airways, as I was discussing in the previous picture, inasal inspiratory flow, positive airway pressure creation, and because of high flow, there is a decreased entrainment of ambient air. So because of heated humidification, increased secretion clearance and decreased chances of bronchoconstriction, and there will be washout airway which creates a decreased dead space, high flow creating decreased nasal resistance, recruitment of atelectatic regions because of the positive airway pressure, and because of decreased air entrainment, there will be inspired FiO2, which increases significantly, near to almost 100%. So because of all these effects, there will be decreased metabolic cost of breathing, decreased minute ventilation requirement, increased dynamic compliance, improved VQ mismatching. So ventilation perfusion mismatching is the one which we generally look at in especially the hypoxemic respiratory failure like ARDS. So these all lead to decreased work of breathing, decreased respiratory rate, and stress strain, opening closing pressures, atelectic trauma kind of thing will be reduced, which may decrease overall mechanical power. These translate into four effects like increased comfort and tolerance, decreased diaphragm load and injury, and decreased villi. This is a very good component, especially compared to NIV and even ventilator, where the NIV, there is a PCL component. I will discuss about that. And there is increased oxygen. All this will lead to good improved clinical outcomes. In a crux, this is how the HFNC, the mechanism of action that helps. So generally what happens, how do we set up? Most of the times, all the connectors have to be checked properly, check oxygen supply, correct fitting and correct HFNC size is very, very important. Highest size possible has to be taken, but avoid too tight prongs because they may collapse, leading to no flow. So this is a very, very important component. And another mechanism where the patient has to be explained to breathe through nose rather than mouth, because of if the patient breathes through mouth, there will be more entrainment leading to decreased FiO2, and PEEP effect will not be very much observed if the patient breathes through mouth. So what are the various clinical applications? Basically, what we generally look at is acute hypoxemic respiratory failure, that is generally commonly used, but it can be used especially in post-surgical respiratory failure and even pulmonary edema. In some papers they have tried, but straightforward indication pulmonary edema and COPD, hypercapnic respiratory failure is NIV most of the times. But still, in some patients who are not tolerating and they are in mild to moderate category, especially this can be used, especially the patient non-tolerance to NIV, it can be a useful modality. And pre and post extubation oxygenation, this is also peri-intubation and even post extubation also is being used in different clinical scenarios, especially there is a hypoxic respiratory failure. Do not intubate in patients. Most of the times we used to use NIV, but I think being HFNC gives a very good comfort to the patient, probably it will help in comfort care. So if we look at various outcome studies in HFNC, they have looked at various outcomes like physiological outcomes, whether the patients getting HFNC versus NIV, intubation, and whether the mortality improved. These are the different outcomes they looked at. So I will go through some of the studies. As Sir was telling about FLORALI trial, which is a landmark, I will go forward and we'll discuss about that also. So acute hypoxemic failure, what is your aim of the treatment? Most of the times, it is to improve the blood gas improvement and then avoid intubation. This is the outcome you want. You don't want intubation because of the villi. So which will decrease the and another outcome is to look at mortality. Along with that, comfort and tolerance and workup breathing has to come down. These are the general aims when we are considering any patient a modality in acute hypoxemic respiratory failure. So, HFNC can interrupt the vicious cycle of lung injury in patients with acute hypoxemic respiratory failure. How it happens? See, if you look at the circle here, initial lung injury leads to capillary leak and then lung edema formation, which leads to this impaired gas exchange and increased respiratory drive and workout breathing, and because of which there is a component of PCL, patient self-inflicted lung injury, which will cause a pendulum mechanism leading to further lung injury formation. So if this type of patients are put on NIV because of a lot of respiratory drive, there is a possibility that the PCL component is very much increased as compared to HFNC, which can mitigate these things and leads to decreased intubation possibilities also. So if you look at the FLORALI trial, one of the landmark trial came in 2015 New England Journal of Medicine by John Perry Fratt et al. So they this is a Raman network where they looked at high flow oxygen through nasal cannula, and along with that they compared the standard oxygen and NIV and the high flow oxygen alone. So almost around 310 patients were included, and high flow is 106 and standard oxygen 94, and the NIV is 110, where they alternated NIV with high flow here. So if you look at the most common indication in these patients, like is community acquired pneumonia containing bilateral pulmonary infiltrate. So 64% of the patients have the indication is bilateral community acquired pneumonia leading to acute hypoxemic respiratory failure. So the liquidate, the p-value here in intubation rate in the overall population, it was not significant attained to the p-value, but still compared to the NIV group, it is definitely low intubation rate. And the significance, p-value significant is especially when they look at secondary outcome, that is 90-day mortality. If you look at in this graph, the high flow oxygen have definitely the cumulative probability of survival on the higher side compared to standard oxygen, and even NIV, it is definitely not performed well as compared to high flow nasal oxygen group. So intubation rate and severe hypoxemic patient, what we discussed in the previous slide was overall, but here in severe hypoxemic patients also, the p-value is significant where NIV group had landed up in intubation more as compared to high flow nasal oxygen around 35% as compared to 58%. So, and they looked at the patient comfort, whether because NIV patients have a increased PaO2, whether that increased PaO2 translated into the patient comfort, because when the oxygenation is more, the patient may feel comfortable, but it does not translate into good comfort. Rather, the HFNC support translated into good outcome as compared to NIV patients. That is about FLORALI study. Of course, there are some flaws in FLORALI study, but still, I think that is considered as one of the landmark study, especially compared to HFNC in terms of hypoxic respiratory failures. Come to apneic oxygenation, another indication. What is apneic oxygenation? So, as everybody know, a patient when we are intubating, especially rapid sequence intubation, we do pre-oxygenate those patients for 3 to 5 minutes to achieve 100% saturation and denitrogenation. But when we are attempting intubation, especially those patients who are sick and critically ill, this is the time there is a apnea happens. So you will not be ventilating this patient. So that is when the HFNC, if it is being applied to the nasal as a nasal cannula to these patients, you are still able to continue the oxygenation while doing the intubation. So this is very important, especially because the critically ill patients, especially obese, pregnant patients, are going to have a decreased FRC and they are going to have a rapid desaturation. So this is an indication where it is very helpful. So this is one study. They looked at nasal cannula apneic oxygenation preventing desaturation during endotracheal intubation. They looked at around 12 studies in this study, which was published in West General Emergency Medicine. So if you look at in this graph, in various studies, they looked at the pre-oxygenation and apneic oxygenation. So during the apneic oxygenation, because of which HFNC was employed, they could able to maintain the saturation as it happens with pre-oxygenation. And if you look at the time to desaturation during intubation in this graph, the patients who had apneic oxygenation with HFNC, in this study, it is around 10 minutes they could tolerate apnea. And in this study, they could tolerate as compared to 6.8 minutes. Another study, 6 as compared to 3.65. 4 minutes and 2.4, 5.29 and 3. So definitely looking at this graph, the patients who are on apneic oxygenation, they could able to tolerate the apnea significantly more prolonged periods. Especially this is very useful when there is a difficulty in intubation kind of situation, because we can safely go for prolonged periods while attempting at intubation. So next indication is post-extubation. So what can happen post-extubation, the acute respiratory failure can happen. Generally, after extubation, the patient is on their own most of the times, leads to lung aeration, decreased lung air, changes in lung aeration, decreased atelectasis, sometimes alveolar edema, decreasing to lung compliance and ventilation perfusion mismatch. These are the reasons they generally land up in the post-extubation acute respiratory failure. So they looked at in different studies, looking at whether the use of NIV versus HFNC during weaning process. Extubation despite SBT failure, this is generally even after SBT failure, to prevent further complications, they could go on to extubate these patients, facilitating onto NIV versus HFNC, which is called facilitative. And extubation after successful SBT, this is called prophylactic. This is acute. After the acute respiratory failure happens, you go for these modalities, that is curative. Definitely, in our experience, we generally go for prophylactic, whether it's NIV or HFNC, rather than curative, because these patients, once they land up in ARF, if you delay intubation, these patients are going to go bad. So this is how they looked at. So if you look at in this HFNC versus Venturi mask after extubation in ICU in one population, in one study, definitely the patients who had, as the time elapses, the patients who are on HFNC are going to do good. Definitely their PCO2 is on the lesser side, workup breathing is better, and then definitely the oxygenation is also better as compared to Venturi mask patients. And another study, they looked at HFNC versus NIV. Here, almost around 604 were randomized between 314 and 290. And the patient's characteristics are like high BMI, Apache on the bit higher side, inadequate secretion management, heart failure. These are all problems in these patients they looked at. So surprisingly, in this study, the NIV patients have more acute respiratory failure as compared to HFNC patients. But reintubation, not very significant, but possibilities of ARF is more in NIV patients. And come to post-operative indications, especially the patients who are having thoracic surgery. One study looked at the effect of high flow nasal cannula versus conventional oxygen therapy in thoracoscopic lobectomy. So these lung surgery patients also, if they are put on HFNC compared to conventional oxygen, the possibility of hypoxemia, reintubation needing NIV will be less, and the p-value, if you look at, is significant in these patients. And post-operative HFNC in abdominal surgeries, I think this is a very interesting, actually important indication, I feel, because especially the patients who are post-operative abdominal surgery, especially upper abdominal surgery, something like a gastric pull-up, a colonic pull-up, or otherwise something like a Whipple's surgery, where upper abdominal anastomosis are there. There you are worried about employing NIV in these patients because of possibility of bloat of the anastomosis and anastomosis problem, where I think HFNC plays a role. I personally myself had experience recently in one Whipple's surgery and one gastric pull-up surgery where we employed HFNC post-operatively after extubation, and they did well. So definitely this is also a very good indication. So guidelines of ESICM say the moderate certainty for hypoxemic respiratory failure, it is strong recommendation. Following extubation and post-operative HFNC conditional recommendation. Peri-intubation period, they did not give any recommendation, but probably in patients who are going to have a difficult intubation, apneic oxygenation helps a lot during performing the intubation. Compared to monitoring, is it very important? Yes, definitely. This is a very important. Just I want to tell about a case scenario, like a case description between those two patients, why it is important. If you look at these two x-rays are looking almost similar, having bilateral definitely pneumonias with PF ratios almost, SF ratios almost same. So if you look at here, the left side of the patient is intubated. So you will have a very good monitoring here. You will have everything possible. You can employ esophageal monitor. You can have good alarm management in the ventilator. But when the patient is on HFNC, you have only one modality, that is looking at the saturation and the patient clinically of the respiratory rate and all. So that is why close monitoring of patients who are on HFNC is very important as compared to the patients who are on mechanically ventilated. So that is where actually the ROX index is being defined and derived. So it is basically measured between respiratory variables assessing respiratory failure that significantly differ among groups. Success versus failure, basically that is the target. So it discriminates very well. The numerator is basically a positive association with HFNC, that is oxygenation. And then denominator is respiratory rate, which coincides with the inverse association with HFNC success. So SpO2 by FiO2 divided by respiratory rate, numerator and denominator gives rise and ROX index. For example, in this patient, if the SpO2 is 88 by FiO2 in terms of 0.7 divided by, suppose the patient having respiratory rate 28, which is equal to 4.48. Generally, the ROX index less than 2.85 or less than 3.85 after 6 hours and less than 3.85 after 12 hours indicates HFNC failure. That means ROX index more, because the positive correlation with SF ratio more is good. So validation of the ROX index. So definitely it is outperformed two variables, whether SF ratio or respiratory rate taken alone or otherwise together in ROX index. Definitely the ROX index performs well as compared to the alone indicators. So if you look at here, ROX index more than 4.88, the success, the cumulative probability free of mechanical ventilation is better compared to the lesser one. So what happens, the ROX index between 4.88 to 3.85, this is the gray area, but in the area around 11% of the entire cohort falls, which will lead to around 33, among them 33% getting intubated. So I will discuss about how we generally look at the ROX index, 2 hours, 6 hours and 12 hours. If it is less than 2.85, definitely consider endotracheal intubation. If it is more than or equal to 4.88, generally continue monitoring closely. But if it is falling in between, most of the times look at delta rocks. That is less than 0.5, go for intubation. If it is more than or equal to 0.5, generally probably the patient can go onto HFNC to continue and continue monitoring. The same thing applies to various other timelines of HFNC support. So that is one very good parameter where we can look at the HFNC success versus failure. So come to the end of my discussion, where iFlow is a useful tool, especially in managing hypoxemic respiratory failure and other indications like post-operative and peri-intubation. And start with iFlows, definitely, and titrate downwards. The FiO2 also on the higher side, titrate downwards to maintain saturations around 92, more than 92%. And when the FiO2 is less, definitely flow can be decreased. Close monitoring is very, very important. Most of the times people don't know about ROX index, but this has to be employed very regularly. Sometimes if it can be combined with NIV intermittently, because continuous NIV sometimes leading to humidification issues, it can be combined with NIV, and patient comfort also improves. Both can be alternated. Thank you. So thank you very much.
Thank you, Kaladhar. That was a beautiful overview of the spectrum of the HFNC use in the recent era. With this, I invite Dr. Arpan Chakraborty, sir. Sir, thank you for being with us once more. And it's always a privilege and honor to have you, Dr. Arpan, sir, on board. And today we have an interesting topic, which is, I think, many of the times I have a lot of interactions with you and Dr. Charan. So first of all, we'll take Dr. Charan's overview on the Awake ECMO and HFNC role. Then we'll take your expert opinion and questions. So over to you, Dr. Charan.
Okay, sir. Thank you, sir, for those kind words. So now I'll be discussing about the Awake ECMO. Okay. So when it actually comes to the application of high flow nasal cannula in a patient who is on an ECMO support, who is actually extubated on ECMO support, we need to understand the ideal candidates. We have to identify the ideal candidates. We have to we can try extubating them on a patient who is on whom ECMO is ongoing, or there are certain patient populations where I will be discussing where we initiate ECMO in a patient who is not quite intubated at that particular point at that particular time. So this patient, based on this patient selection and based on the initiation, based on the indication for the initiation of ECMO supports, we can actually try patients to be extubated on this, and we will just discuss briefly about how HFNC might be actually helping in these patients after they have been extubated on ECMO support. So what does Awake ECMO do? So a patient who has been recently, who has been weaned off sedation and completely off sedation and kept cognitively active on a running veno-venous extracorporeal membrane oxygenation support, it facilitates physiotherapy and rehabilitation. Firstly, because of cognitive activity, we are also we are essentially facilitating physiotherapy and rehabilitation in these patients. And these patients, it decreases ICU delirium because of the decrease in the use of sedatives and narcotics. It also decreases the incidence of post-intensive care syndrome, where there is decrease in the cognitive capability of the patient when the patient is typically associated with increased ICU admission or increased ICU length of stay, which can be anticipated in patients who are initiated on an ECMO support. So patients who are initiated on an ECMO support, we can anticipate that these patients might actually be coming to the ICU in a quite bad shape. They get intubated most of the times, and generally in our Indian scenario, we'll be initiating them on ECMO within 24 to 48 hours. So in these patients, and then an ECMO run typically can run up to 10 days to 10 to 14 days, especially in a case of venous ECMO. And so at least 10 to 14 days of is the average ICU length of stay for a patient who is undergoing extracorporeal support. So in such length of stay associated with judicious use of sedatives and narcotics can be associated with cognitive decline or immediate in a acute post-hospitalization period. So this can be actually prevented when the patient is awake and interactive with minimal amount of medications, which can for analgesic purposes only. So extubation on an ECMO requires a standardized approach. So the thing is, we have to first identify the patients. As I was telling you before, these patients have to be initially identified, and then based on a criteria which are not internationally defined. ELSO has actually given some criteria which can help in understanding what patients can be adequately extubated, but it did not actually give us a very clear guideline on whether there is no head-on comparison between extubated patients and intubated patients on extracorporeal supports. So you can actually see in this particular slide that where it was done by Robert Roncon et al. So standardized approach for extubation during extracorporeal membrane oxygenation. It's actually an observation study, but with reasonably good numbers. They have done around 250 patients on an ECMO was actually studied, and you can see that the amount of patients who were extubated was around 20%. Then, but if you actually compare the incidence of mortality, incidence of ventilator-associated pneumonia, nosocomial infections, and obviously the need for a tracheostomy, you can say that even in in many forms of statistical analysis, you can actually see that the p-value is significant in almost all of them, where the incidence of mortality is like the survival is better in patients who are extubated, the incidence of VAP is better in patients who are extubated, the incidence of nosocomial infection is lesser in patients who are extubated. Everything comes with a statistical significance. So we can actually establish the fact that patients who are extubated and who can tolerate extubation, probably instead of actually discussing the fact that should patients be extubated on ECMO, this particular study tells us the fact that those patients who tolerate extubation on extracorporeal membrane oxygenation support are the ones which have higher chances of survival. So if at all a patient gives us that chance, it is imperative that we take the chance. So what is their protocol? Because we don't have established protocol on how to select patients, we have been actually extrapolating from their study at this point. So we have seen that with severe ARDS with failing intermittent mechanical ventilation, we can say that for 254 patients, they underwent an ECMO cannulation. So if at all there is an absence of bleeding, shock, or acute brain lesion, obviously, and then there comes clinical criteria as well as gas exchange criteria. The clinical criteria being the cooperative patient, manageable secretions with no artificial airway or no airway obstruction. In these patients, if at all the gas exchange criteria are also matched, so if the PEEP requirement is less than 10, on mechanical ventilator support, if the minute ventilation is less than 10 liters per minute, and sweep gas requirements and pH requirements can be actually adjusted based on the patient cohort. And then these patients were actually seen whether or not they can be extubated, which is around in 54 amount of patients. And then there is a control group. So the control group was managed as per the regular ECMO management on mechanical ventilation. Probably they were subsequently tracheostomized, etc. And in these patients, you can actually say that in 43 patients, there is incidence of successful extubation, and then there is a failed extubation. So they have actually been saying that the major complication, not exactly the complication, the major issue was that two of their patients in the all of extubated group, they had accidental decannulation of the cannula. So which is not a very high incidence, but they are emphasizing the fact that this has to be done on this has to be done carefully, and careful monitoring has to be done so as to prevent such kind of accidental decannulations. So what does ELSO say? What does ELSO say regarding criteria for extubation on ECMO? So then first of all, we have to assess the readiness of the patient. Then obviously there is a gas exchange criteria and extubation. So how to assess readiness? As it is something similarly of what we were discussing in the previous slide. There should be an absence of multi-organ failure. Ideally, patient should be hemodynamically stable. If the patient is awake and cooperative enough and at least maintain the airway and not pull out the lines, secretions should be manageable and they should not be having constant accumulation of secretions or copious amount of secretions which warrant frequent bronchoscopies, or if the patient is not able to cough. These and patients who are requiring higher amount of PEEPs to keep the lung open, ideally they should not be included, because even if we extubate these patients and even if we institute them on HFNC support, highly PEEP dependent individuals might not do well. So then the gas exchange criteria. The gas exchange criteria should have acceptable arterial blood gas on minimal ventilator settings. So ideally, as I was discussing, minute ventilation should be less than 10 liters per minute. So then take an informed consent, do a significant chest physiotherapy, ideally do a bronchoscopy before extubation so as to clear all the residual amount of secretions. And we can extubate them onto HFNC support. Extubating them onto non-invasive ventilation is per se probably is not going to cut it, because there are times where the patient might be requiring constant NIV support, which is not a very patient-friendly thing to do at this point. So, and then obviously these patients should always be ready for getting reintubated. And so we can actually see how we will adjust the ABG and adjust the sweep post-extubation in these patients. So the other important thing which can be done in this particular scenario, or what we typically follow in our institute, is that we will be not the higher. There are two schools of thought here, where the patients typically who are on an ECMO and who are extubated can be having some degree of happy hypoxemia, where they'll be able to tolerate around 82 to 85% of saturations without having a hypoxic respiratory, without initiating their hypoxic respiratory drive. In these patients, especially all these patients who are extubated, we have to adjust the limits to such a way that we are actually not triggering their respiratory drive. So the respiratory drive, as we all know, comes from hypoxemia and hypercarbia. So the ideal thing is to maintain reasonably good saturations around 88 to 92%, as opposed to patients who are ventilated, whom we have a certain leeway where I can actually ventilate the patient, where I can accept a saturation of around 85% or 80 to 85% also. The problem is that if the patient is not tolerating saturations of 85%, even though the clinically normal, there are no hypoxemic the biochemical values like lactates, everything might be normal, but a patient who is saturating at 83, 84% constantly might trigger his hypoxemic drive, and he might get tachypneic, or there might be subjective form of shortness of breath. So this is one of the criteria where we have seen that these patients might get reintubated. So this is where extubation typically fails in these patients. And coming to the sweep gas flow also, we will typically maintain the sweep gas flow such that the PCO2 levels are around less than 40, 35 to 40. Not in patients who are having on mechanical ventilator, we can accept higher sweep values also, but again, higher PCO2 values might again trigger the respiratory drive, which can get translated into subjective feeling of shortness of breath in these patients. So to keep them symptomatically active, our targets will slightly change a bit, albeit not unphysiologically, but we'll be just trying to we will be trying to maintain these targets on a more normal physiological scale, rather than accepting the lesser values or more PCO2 values as we typically do in a patient who is on mechanical ventilator. So then comes, as I was discussing you, there is a advantage of these patients undergoing physiotherapy and rehabilitation. Most patients who will be undergoing physiotherapy and rehabilitations are the ones who are being bridged to transplant. Other patients, it is not imperative that we make them sit, stand, or walk with femoral cannulations. But the thing is, if at all the patient is being bridged to lung transplantation, this ambulation becomes all the more important while bridging them to transplant, because if they develop critical illness myopathy, their survival chances and the hospital length of stay is going to increase significantly. So when we have, typically we don't use like dual lumen cannulas because of their cost constraints. Most of our cannulations, around 75% of them, are single lumen cannulation from the femoral cannula and interventricular cannulations for a veno-venous ECMO. So we have this apprehension that femoral cannulations are there, and then this patient cannot be made to sit or made to stand. But the thing is, in patients who are awake, who are cooperative, especially, and then we can actually say that the femoral venous cannulation should not be considered a contraindication. Okay, and these patients can be rehabilitated, or they can be even made to sit on a chair or made to stand, and they can actually take a couple of steps where it helps with their overall maintaining their muscle mass, and thus improving the post-operative outcomes when it really comes to patients who are being bridged to transplant. In ARDS patients, we typically did not take such steps where we made them out of bed, etc. We are making them do active physiotherapy exercises in bed only, whereas this ambulation thing comes to play only if we are dealing with patients who are being bridged to lung transplantation. So what are the advantages and disadvantages of Awake ECMO? So obviously there is maintenance of physical activity. But the thing is, we have to take into consideration the risk of catheter dislocation. So very stringent monitoring has to be done to prevent that. There is obviously spontaneous breathing. The spontaneous breathing is actually helpful in maintaining the respiratory muscle and diaphragmatic function. It maintains the expansion of chest wall and lungs and favors venous return. So sometimes what happens is, as I was telling you, if you are stimulating the respiratory drive, we are essentially making them increase their transpulmonary pressures, or there is high risk of self-inflicted lung injury which can happen. So because patients are completely awake and they are not sedated at all, their metabolic rate might increase. So we can say that there is an increase in oxygen consumption as well as CO2 production, which has to be taken into consideration. So by preventing intubation, we are essentially decreasing the risk of ventilator-associated pneumonia, but there might be a chance where emergency intubation might be required. So through the reduced dose of sedative and analgesic, as I was telling you before, we are essentially decreasing the risk of delirium. We are enhancing the communication with the medical staff, and they will be present during their own improvement. But sometimes, if you are dealing with patients who are in pain, discomfort, or sometimes the patients might get significantly anxious. So what are the problems during awake ECMO? So problems which can occur during awake ECMO are obviously like this is somewhat of a issue which we are discussing. So there might be hypoxemia, so increased work of breathing, difficulty removing secretions, and if even if the patient gets anxious, essentially what happens is we are increasing their cardiac output, and when the cardiac output is being increased, we have to because the ECMO flow is relatively constant, when the cardiac output increases, they can face desaturation. If they are desaturating on an awake ECMO, what typically follows is a vicious cycle. So they'll be desaturating, and then it increases their work of breathing. It increases their work of breathing, can actually trigger their anxiety, and anxiety further increases cardiac output, which will cause further desaturation. So we have to break this cycle. So judicious use of minimal amount of sedatives might help. Or as discussed previously, in this particular scenario, the use of high flow nasal cannula is of significantly important modality, where we can actually give them a good amount of flows. By improving the flows, and because of tracheal insufflation, we are essentially decreasing their work of breathing. We can give additional oxygen through the nasal cannula, which can improve the hypoxemic part. And it also decreases the work of breathing, and by use of humidified oxygen, this even their airway toileting can be done quite better. So it is at this particular scenario where the patient might be hypoxic with some anxiety, saying that he's not getting enough air to breathe. So HFNC might actually be a better modality to intervene in these patients. So we can also see because ROX index and everything what we were discussing about might not, it is not practical for us to calculate the ROX index during when the patient is on an ECMO support. So in this scenario, all we can do is, based on their work of breathing and based on the patient comfort, we can actually go ahead and try HFNC before re-intubating the patient. So we can actually delay intubation even if the patient is on ECMO while using HFNO support. Then comes anxiety and agitation. As I was telling you, this can be a vicious cycle also. So judicious use of analgesics and sedative drugs. Patient might be moving, and there might be certain kinks in the catheter which can come up, which can cause chattering of the catheter, or the patient might be hypovolemic. And because of the negative pressure in the pleural space, because of spontaneous breathing, sometimes there might be some collapse of the veins onto the drainage cannula, which can cause chattering of the catheter. So we have to correct hypovolemia and adjustment of the ECMO flows based on the catheters. So in patients, they might be developing some progressive right heart dysfunction or pulmonary hypertension. So this particular thing might not actually necessitate intubation, but we might have to change the modality of ECMO to even support the right heart. So the major issue which can come is if a patient is a little agitated and if the Richmond agitation sedation score goes more than +2, then we are essentially at a risk of patient pulling out the catheter or accidental catheter decannulation, which has to be prevented. So this is one of the reasons where the patient is getting irritable. We will not take a chance. We will rather intubate the patient at this point. So to discuss about why HFNC complements awake ECMO, so there is respiratory support, there is oxygenation security. So respiratory support by reduces respiratory effort and dyspnea while supporting spontaneous breathing patterns. So it is much more comfortable because of optimal airway humidification, warmth, and it is better tolerated than non-invasive ventilations and invasive ventilation strategies. Then there is oxygenation security, which helps prevent dangerous hypoxemia during ECMO weaning trials. So, and we also have freedom to mobilize. So our experience is that you can actually see in this patient, it's a 21-year-old male with scleroderma on long-term oxygen therapy, was awaiting lung transplant. So we can see that this patient has, we were able to extubate this patient on veno-venous ECMO support. And as I was telling you in one of those slides previously, that even if this patient is having a femoral venous single lumen cannula and an internal jugular single lumen cannula, so this need not be considered as a contraindication. This patient was so comfortable with our ECMO settings that we need not even put conventional oxygen for this. So we can see that this is a testament that patient can be extubated on ECMO support, and this is him after we did the lung transplantation. So after lung transplantation, he was successfully discharged. So this actually tells us how extubating on ECMO is possible, and then how much we can actually help, how based on the settings we can actually mobilize and ambulate the patients even on ECMO supports. So this is another patient with 40 years of female with progressive shortness of breath. So she is not a patient who for bridge to lung transplantation, but she is a patient with ARDS. So we initially this is a case about awake, patient being completely awake on an ECMO support with minimal ventilator support. She was on pressure support at that time. So we later then put her on HFNO support, which is with a tracheal connector also. But this lady was actually tracheostomized. So we extubated this lady, but at the same time, she was actually having those symptoms of significant shortness of breath where we had to reintubate her, and then we did a tracheostomy. And after tracheostomy, because with ancillary ventilator support and all, she was completely comfortable. So you can actually say that this patient during the initial ECMO support, lungs are completely wiped out. So if the patient is having a very low compliant lungs, sometimes they might not be able to tolerate extubation because it is their tendency to actually take a full breath, and because of the very low compliant lung, they can hardly take any tidal volume. So even that can actually cause relative personal sensation of shortness of breath in these patients, even though they are maintaining their vital signs. So this is another patient with severe type 1 respiratory failure secondary to interstitial lung disease. She's a 65-year-old female who was bridged to lung transplantation. So because it was actually a bridge to lung transplantation, and given the age, we thought we'll ideally have to extubate this, because the intubation means or prolonged intubation means the more risk of ventilator associated pneumonias and other infections. So this lady was extubated, and then we were able to make her do significant amount of exercises while she is being bridged to lung transplantation. So this lady was actually on ECMO for about 40 days because for various other reasons. And after on the 40th day of ECMO support, she underwent lung transplantation. And after lung transplantation, we were able to extubate this lady early. And then she was also discharged home. So patients who are being bridged to lung transplant on ILD, which warranted 40 days of an ECMO support, probably she might have suffered significant amounts of muscle dysfunction and critical illness neuromyopathy if the patient was on intubation with significant amount of muscle relaxations and all. So this is her post-lung transplant. So to conclude, so all patients on ECMO, we can actually try to be kept awake and ambulated. So whether or not to extubate, or whether or not to do a tracheostomy and then keep them awake is something which can be taken on a patient-to-patient scale. So it facilitates early ambulation in physiotherapy. So ideally, bridge to transplant patients are more preferably extubated, because ARDS patients there might be a requirement where they will be they are having PEEP requirements and all, which might not be possible if the patient is extubated in these scenarios. But if we have to make sure that are these patients based on the criteria check. So are these patients extubatable, or can they stay extubated is something which we have to decide prior, and vigilant monitoring is required. And obviously there should be trained staff, and there should be, as I was telling you, the accidental decannulation should be avoided at all costs. So yeah, thank you, sir.
Thank you, Charan, for bringing those discussions. Now I request Dr. Arpan Chakraborty sir to be on board. To start with, can we take out the slides, Charan?
Yes, sir.
Dr. Arpan, in the last maybe a decade or so, from days of ECMO in 2009 pandemic, where patients were first paralyzed, sedated, restrained, then ECMOs were placed, and the relaxants were on the top notch with trainer for monitoring to ensure that they are not moving. From that era, we are talking about patients walking on a bridge to transplant ECMO patients. So, but this is again a very maybe small subset of patients who actually tolerate so well. But in real world, things are in a different. It's not so blue or green. So, what is your experience? See, we see a very wide spectrum of indications from a severe ARDS patients being put onto a VV ECMO to a patient with an ILD was initiated on a VV ECMO with a HFNC or a oxygen therapy to a patients with a paraquat poisoning where we put HFNC and then put a Awake ECMO, don't intubate them kind of thing. So what was your experience in the last decade of these different spectrum of cases behaving? And as Charan was talking about, they getting into that suitability for getting extubated and the success rate after extubation also.
So thank you for calling me in this the academic thing. Just if you have asked for the journey, we have seen this ECMO thing from never extubate to extubate and Awake ECMO, and then we are actually going towards assess and extubate. Nowadays, what we do, it's an assess and extubate and some cases of Awake ECMO. Now, if you go through the journey, I just opened one my PPT which I have made in 2022 because Awake ECMO or extubated ECMO came into very much picture during COVID.
Yes.
Because the unusually prolonged ECMO run and people are having these bad lungs with recurrent infection. So if you get rid of those ventilators, which are giving only 5, 10, 15 ml of tidal volumes, nothing else, if you can get rid of those ventilators and put the patient on ECMO, it would have been easier to manage. But surprisingly, we have been miserably failed during that time. And we know all of us has failed this thing because of the pattern of ARDS the COVID has given to us. Because once you have extubated the patient, somebody is generating 1050 of tidal volume without any contribution to the oxygenation, and more, as Charan has rightly told, you are generating more tidal volume. It is you are going for more workup breathing. It is increasing more your cardiac output, and you are desaturating further. So that person also we have seen that it was not working. So what had actually led us to the world area of Awake ECMO is basically it is a transplant patient. Waiting transplants are probably it's a clear-cut guidelines for the transplant patients where you should do kind of Awake ECMO or the patients immediately extubated after ECMO if they are intubated. So this is a clear-cut guideline for us. Another one I want to put your attention, like this patient you have put in the scleroderma and all these patients who are immunocompromised by some other means, like you have some disease which are like your PCP pneumonia or something else. Here you can try your Awake ECMO just to reduce the further VAP during the stay in the hospital. So these two patients were the kind of patients where Awake ECMO should be practiced. Now, coming to our day-to-day bread and butter of ARDS, what we do, what we can do. If you see for the first 7 days of ARDS or first 10 days of ARDS, where the inflammatory phase is still on, in these patients, we cannot extubate them. Even forget about extubation, we cannot make them awake. They're so restless, they can't breathe, they need higher PEEPs. So if you divide these ARDS patient in between requirement of high PEEP and a low PEEP, I will recommend that you should not try of any kind of extubation or Awake ECMO when they are requiring a high PEEP, because HFNC doesn't confer any kind of PEEP for this kind of patients. So high PEEP ARDS inflammatory phase, probably Awake ECMO is not your cup of tea. Coming after 14 days of ECMO, when you are thinking the patient is recovering, the lungs are getting better, and you till you want to keep the ECMO thing run, and you want to extubate them, probably that is a good decision if the patient is doing fine. On that contrary, I want to tell you, awake extubation or extubation on ECMO should be very much individually prioritized. In a ICU, which is less manpower, and probably you are not catering adequate look after to this patient, the patients who are extubated on ECMO or awake ECMO, if sometimes they got agitated, there is a chance of dangerous decannulations and catastrophes can happen. So always you have to individualize this kind of patient. Any slightest ICU psychosis or any kind of hypoxic psychosis, whatever this kind of patients is having, I will not recommend any kind of extubation, or rather to prevent all these accidental things, because this can lead to serious catastrophes if you don't manage them. Number 4, the patients whom we extubated, what we are going to see. One of my old presentation I have written, this monitoring during awake ECMO is the respiratory rate, patient is dyspneic or not, rapid shallow breathing, patient is breathless, small, rapid, shallow, any paradoxical breathing has appeared, or you have extubated in the morning and by the evening patient has started paradoxically breathing. This is the thing we have to see. Another 5th point, what we don't measure, but that is written in a very good write-up, that is esophageal pressure swings. If you measure esophageal pressure and if it is more than 15 centimeter of water, that patient needs deep sedation and switch to conventional invasive mechanical ventilation. So these 5 points, respiratory rate, dyspnea, any rapid shallow breathing is appeared or not, or paradoxical breathing. These points you have to very much cautiously, you have to monitor if you have extubated that patient. Otherwise, you are going to, your extubation is going to fail, or your awake ECMO is going to fail in this kind of patient. And obviously, for the sake of physiotherapy, for the mobilization part, you have to, these awake patients give tremendous benefit over this sedated and paralyzed patient. Though in my regular practice, awake extubation I have kept with a very much, what should I say, in a very controlled way, in a reserved manner. I don't usually extubate them normally until unless I'm fine with the patient is not doing to, like having one patient is having a severe right heart dysfunction, and I had to extubate this patient because of some problems in the throat, and he was gone to, that patient actually did very well after extubation. His PA pressure was more than 100. After extubation, it came down to 60. The HFNC worked well. She was on ECMO for 21 days, and we could take out the ECMO. So probably these are the cases where are not so common, but this kind of patients have really performed well if you have done it judiciously. So to cut the long story short, from an area, from an arena of never extubate to awake ECMO to assess and extubate and probably reintubate early, this is the thing where we are actually standing on. Yeah. And just a last pointer, what I'm just finding it out that where you are actually query no intubation, so not sure about safe decannulation or cannulation. If you are decannulating the patient in extubated condition, you have to be very sure that will not lead to any kind of bleeding or vessel rupture or vessel thing, because most of the time we are talking of the VV ECMO, but awake extubations are very common in V ECMO. When you are putting the patients for LV dysfunctions, because as the LV dysfunction is over, you have extubated the patient, wait for the lung, your heart to recover, and they then decannulate. I have seen people have died during awake decannulation of peripheral venoarterial ECMO. So be cautious. If required, during that short procedure of decannulation, you should intubate, take in the OT, or you decannulate. So be for the sake of extubation, or sake of the patient keeping awake, you don't try go for a bad decannulation practice at that point of time, because you are going to lose this patient. Obviously, respiratory drive PCL is much, you have to keep watchful.
Yes.
If the patient respiratory rate is 40 to 50, don't allow that to happen even on ECMO. Profound tachypnea with requiring high sweep gas flow on ECMO. This has to be kept in mind, because when you have extubated the patient, the sweep gas may be 5 liter. Slowly it has gone up to 10 liter, 12 liter, 15 liter. That means things are failing. Controlled use of sedatives. You might need to use some fentanyl infusion or some kind of sedatives just to keep him calm and quiet during this awake ECMO thing. And managing catastrophes and circuit problems, these are the main things. And proning is not possible till now on awake ECMO. I don't know whoever has done, anybody has done it or not, but I have not done it awake proning on ECMO. So thank you.
So it's difficult, very rightly pointed out. I think from an era where we were actually talking about sedating, paralyzing, keeping them completely knocked off, first component is we made them no paralysis, deep sedation. From there we came no paralysis, light sedation, or maybe erosible. Then we are talking about extubation. We are first talking about keeping them awake, restrain them, keeping them awake on a light sedation, anxiolytic, some melatonin, some dexmedetomidine, keeping them calm with a maybe RAS index or sedation score of -1 to 0. And we are talking about the last component, extubation. Dr. Arpan, you made a very right point. If your center exclusively puts ECMO for a respiratory failure ARDS, the number of awake ECMOs will be extremely low. The reason is, as you said, the inflammatory phase followed by that. Whereas Dr. Charan and our center, we see 60 to 70% of patients will be an awake ECMO, because the spectrum of cases are different here. We do cases from your unit or any other unit who have been there as an ARDS patient for a month and then transferred to us for a transplant. And by the time this inflammatory phase is gone out and the patient was tracheostomized, and now we are slowly trying to actually bring them out of sedation, trying to make their muscles work. Our transplant surgeon says, if you are planning to go for any transplant, make them awake, make their muscles work, they have to be active, then only I'm going to take. If they are in critical illness polyneuromyopathy, if their muscle function is 0/5, they are not a candidate for any form of transplant.
Yeah.
So this is the cohort. There is another interesting component happened in recent times. I will express my experience about paraquat.
Yes.
And I just wanted to tell this audience that the first two paraquat end-stage lung failures where we transplanted a couple of years back, they're still alive, and they've been doing, we have been publishing, try to be a part of in Lancet publication, and it will be one of the earliest and one of the youngest patient with 14 years. We transplanted 4 months back in High Tech City. That patient is also being walking to us every week for the follow-up. So these are another ball games which we recently explored. When these patients comes to us, putting them onto ventilator has been a futile. So we put them onto HFNC, and at a point where their oxygenation and CO2 builds up and we know they need some kind of support, we under the sedation put them onto ECMO and HFNC. We try to manage them as long as it is possible. But again, they will be bridged for a transplant. There is no question of decannulating or doing something. But sometimes, as you said, we fail because of, as you said, air hunger, their increase in cardiac output, as Dr. Charan said. So this is you first need to have that exposure of that whole spectrum, which patient is suitable to get awake, and then which patient can get extubated, and probably which patient may need re-intubation if you have trialed an extubation. But as you said, you have given and rightly pointed out the transesophageal pressure variation. That is nothing but probably pleural pressure variation, which we were talking about monitoring for PEEP titration in obese intra-abdominal compartmental syndrome patients. That is again a clue that these patients are trying to breathe harder with such a high pressure swing. So that means the same thing, as you said, they are dragging around 1000+ ml of tidal volume, which itself, we are talking about a bridging for recovery in ARDS patient, can harm your patient. In
Sure.
patients who are actually, for those who are actually planning for a transplant, may not make a difference because they will never generate a tidal volume more than 200 or 150.
Mm.
The lung is
They are
stable.
better. They are better probably.
They are a better patient than that. So you rightly pointed out, it is all depends on which kind of patients category you get, and the best patients are probably the chronic patient who are slowly decompensating. You put them into Awake ECMO, keep their muscle function reserved. That's one category. We now trialed in Paraquat, another category. Third category, the patients who actually come to us after those initial phase of bridging to recovery.
Fibrotic phase of ARDS. Fibrotic phase.
Bridging to recovery to bridging to a transplant and transfer to us for further care, which Dr. Charan receives in his transplant unit. We try to actually make them awake first, then our physiotherapy teams bounce onto them to make them do some physiotherapy. These are the spectrum of things. So Charan, any of your comments on this part that you are the 2-3 important point Dr. Arpan made key. One is if your staff is not alert, in a fraction of second with this delirium, this patient can cause catastrophes. How much is the worry for you in many of those situations?
It's like for a patient who is like relatively calm, these patients we can actually try an extubation, sir. But the thing is, if at all they are showing initial signs of delirium where they are not really cooperative, probably at this point itself we'll start sedating them because it does not take much time for them to pull out the cannula. So they
That
don't
is the
really
thing.
give us.
Fraction of second they will pull out the cannulas.
So
Not even.
So we should
What
be.
is that? What is that sedation? Do you actually keep them some boxing gloves, some restraint, which is possible?
Preferably, if the patient is such way that we have to put them on boxing gloves or restraints, I don't generally extubate those patients. I will rather tracheostomy.
What kind of sedation will you
So
do?
we are typically using morphine sedation, like morphine sedation, dexmedetomidine, fentanyl. They'll be as the days go by. What we have seen is that they'll be requiring very monumental doses of fentanyl support. Probably that is not something that is going to help.
So dexmedetomidine is the standard, but probably on a chronic situations we use a small dose of opioids or like
opioids.
Morphine in a dose of.
So I'll start generally in tablets, like on 10 milligrams on a thrice to 4 day.
Any role of antipsychotics in them, even though we are not talking about extubation, but these patients even on ventilator, dropping relaxant, dropping sedation will also be a huge challenge. I've seen, as both of you have explained, whenever these patients get agitated, they get awake, they try to breathe harder at a 40 rate, and your cardiac output goes to 8 to 10 liters and you desaturate, as you rightly point. What kind of other measures you take, Dr. Arpan, in these cases?
So anxiolytics.
Charan, I'm just trying to find out from Dr. Arpan.
Yeah, sure.
Yeah, this other mode of anxiolytics you can take, like your Serenase is one of the good thing. Injectable Serenase. You can use it for. Dexmedetomidine, I have found it is not much of effective in that kind of agitation and this thing, because this is too much of it's too mild to this
Control.
thing. Too mild to do these things. Surprisingly, if you have found these things, people have used in like some patients where patients are having this larger tidal volume and all these things, they have used a lower dose of muscle relaxants.
Partial
muscle relaxants, just to reduce this tidal volume, just to reduce the villi and all these things. They have used that PCL just to reduce the partial muscle relaxations. So probably all these things, and rest of the times probably giving your all these oral tablets what the psychiatrists use, you can add on. But I have not get much of benefit out of this. Sometimes a little bit of propofol sedation also works on them.
So as you said, and when we were medical students, partial muscle relaxant was considered to be a crime.
Yes. So the paper, I have forgotten the paper where they have used. Charan,
now it is a new norm that you don't need to actually keep the train of 4-0. You can actually partially paralyze them. Your recovery will be quicker, faster. You don't really need to knock them off, but keep them calm. If they are immobile, that's fine. You don't need to be completely taking away their all neuromuscular blockade to extend the.
Yes.
So, Dr. Arpan, where do you see now we got an idea that these are the things. So where do you see how we should actually go from the stepwise to that point? You made a very clear criteria. You spoke about if my patient's tachypnea is worsening, my respiratory rate is going up, my sweep gas flows is going up, I have a swallow breathing, paradoxical breathing, my swing in my esophageal pressure monitoring. All these are criteria that I may need to reintubate these patients. But how do you go? So, for example, if I'm putting a VV ECMO on a intubated ARDS patient, probably if I'm going through a normal course of slow recovery in a week or 2 weeks, probably I will wait for my ECMO to be weaned and my ventilation to be optimized, so that I will wean ECMO, keep on ventilator, and slowly wean ventilator later rather than taking out. But where do you actually take a call? Probably it is now time to probably do a track and wait a longer. Where do you think is the time? You said inflammatory phase a couple of weeks or more. What is the timeline you think so?
See, to be very practical, other than the transplant units and what you have told, the paraquat, where actually the lung is actually compromised, you are not getting anything, you have no expectation from the lung. Or lung damage and all these things. The rest of the patients, like in ARDS and all these things, extubation in ECMO should be performed at least 2 weeks, give a good 2 weeks to the patient.
Yes.
Because otherwise, what will happen? All these things goes for a message to the people who are practicing ECMO in different cities. I have seen a lot of people have started doing extubating these patients prematurely, and that led to a lot of catastrophes. So a clear-cut 2 weeks gap should be given in case of sure shot ARDS, like viral ARDS, or kind of the patients, the bad ARDS, what you have seen. A clear-cut 2 weeks should not be extubated. That should be this thing. Number one. Second is extubation on ECMO should be performed categorically in those patients where heart failure, LV dysfunction, and this patient actually got benefited from there, because you have given ECMO for your heart and keep them intubated, led to a bad VAP, and patient died because of this. If you have seen, if the patient's coming out of VA ECMO and the patient dying of sepsis is a bad thing. And we have lost a lot of people from this. So whenever they are coming out of their your pulmonary edema kind of thing, and they are doing good respiratory, showing good respiratory reserve, they should be extubated. So from a VV after 2 weeks, VA after correction of your lung thing, the pulmonary edema thing has gone up, and you are requiring still some kind of VA support, you can extubate then. I will tell these 2 categories we should try, and rest of the time in a transplant unit like yours or a paraquat, this is a very good yes from us. And third one, I am talking about the patients who are immunocompromised. There are a lot of publications which came. The patients received ECMO for after bone marrow transplants. The patients, the babies who got received ECMO after, say, treatment for different leukemias. These patients, you should consider early extubation just to prevent ventilator-associated pneumonias.
Okay, but you said VA ECMOs where the pulmonary edema is resolved and your VA ECMO is able to support circulatory system and his LV is reasonably holding on without any new pulmonary edema, they're early coming out of the ventilation because you have exclusively kept the ECMO for supporting the cardiovascular system rather than a pulmonary system. Is that what you are saying?
Yes. We are predominantly in low cardiac output situations.
Waiting for a myocarditis to recover.
Myocarditis. MI is also a thing. Where this.
So what is your take on that, Charan? And what is your experience with cardiac cases or a post?
Actually, in cardiac cases, we have actually extubated some patients who, as Sir was rightly pointing out, when the the X-ray looks completely pristine, and like we can actually see that this patient will be generating good amount of tidal volumes and etc. The one thing what difference we see when we are extubating patients who are on ARDS versus VA ECMO is that when I'm actually trying to extubate a patient from an ECMO whom we put for respiratory reasons, we will see how calm is the patient and how well he tolerate extubation from a clinical point of view. Because anyway, the oxygenation it is being taken care of by the lung. Whereas in patients whom we initiate ECMO for VA or like cardiac causes and then contemplate an extubation, we take into consideration the improvement of the lung in these patients before we extubate. Like the X-ray should be better, their compliance should be better, they should tolerate a proper spontaneous breathing trial, put them on pressure support, good amount of and this is the subset of populations whom we try to extubate on.
You also experiment this with the post-transplant cases where you pull out tube first, then ECMO in a rare situation?
We have not tried that, sir. We have not
We
tried.
generally
There are certain
take out ECMO and then
take out ECMO and then take the
and then probably if needed tracheostomy also if situations arises, but not as a modality to other way.
in immediate post-transplant period, these patients might be having, if the patient in the immediate post-transplant period is on ECMO, essentially we are talking about where the patient has got significant primary graft dysfunction. So in the initial points where the patient is having significant primary graft dysfunction, it is more like a non-cardiogenic pulmonary edema kind of picture where they'll be PEEP dependent. So
That's an acute problem. So you cannot
yes.
extubate them.
Yes.
The question of extubation.
Avoid them with that. So last point, Dr. Arpan, we were actually trying to focus on the role of HFNC in those cases where we could actually have a small space, as you said, the patient who are for bridging for a transplant, maybe this kind of paraquat poisoning on some of these cases where we are just waiting as a fibrotic phase. How will HFNC fit there? We were all discussing, today's topic was more so for that.
See, they have discussed it very well, the HFNC role of HFNC after extubation. I will point out one thing. HFNC has helped us in putting ECMO in awake patients. That is one part where HFNC scores over other things. You can give a small nasal cannula if the patient is stable on ECMO, extubated. You can give mask, whatever you can. They can tolerate as per their flow need. But when you are putting ECMO in a patient, thinking that they will, you want to keep them awake during the ECMO, HFNC actually scores over that. Peri-procedural ECMO in awake patient, HFNC scores over of its other modalities, because BiPAP and all these things, sometimes a lot of problem happens, intrathoracic changes and all. You are going to cannula in the neck, it takes a lot of breathing and that causes problems, positive pressures, puncture the fluid, and a lot of things can happen. But HFNC has eased out these problems when you are putting the patients on ECMO, this kind of patients. So probably in paraquat and all these things, I don't know how you have intubated in awake patients. You try HFNC, they're doing better.
So we had around 10 cases where we actually put a awake ECMO bridge to a transplant. All of them, our standard of care is when they are on HFNC, when your FiO2 is 100 and you are saturating to below 85, 80, that is the time where we actually directly cannulate and put on ECMO and maybe local anesthesia with mild sedation, anxiolytic to keep them calm, counsel them well, give them a reassurance that you will be all right. This will help you to actually tide over that. But sometimes air hunger do happens in them. We do see with fever, with some sepsis, some secondary infection. So how do you actually, that can actually again be always...
No. On those cases, you have to intubate. Otherwise, HFNC failing means I don't think much of scope you have. Intubate, sedate, and then put the. You keep your ECMO thing ready, just intubate and put the patient on ECMO. We have done it. All of us have done it.
Yes. So thank you so much, sir. It was a wonderful, fruitful discussion. Yes, we don't want to carry that message that all patients who need a
that is the best.
Should be attempted to extubate and keep them awake. That's not our goal. Our goal is to make the patient better, send the patient safe and in a recovery state. These are the subset of population where probably extubating them to a bridging for transplant or waiting for a transplant or waiting for a lung to get, those are the areas, or a fibrotic patients where you have end up, as we discussed Acute, when we actually initiate direct ECMO on a awake patients where the indications, and keeping them probably mobile, physiotherapy, rehabilitation when they needed ECMO for more than a couple of weeks or so is again one more area to, as you said, it is not just about recovering of the lung, the whole maybe critical illness, polyneuromyopathy, cognitive function, nutrition status, other things holistically need to be taken care. That comes as a part of it. So with this, I thank Dr. Charan, Dr. Kaladhar in bringing those discussion. I thank Arpan sir, as always, the lively, very practical discussions to bring. And we thank all the audience for being there and participating. Thank you. And I conclude the session. Thank you very much.
Thank you. Sorry for being me late. Little. Fine.
Thank you,
Thank you.
sir. Okay.
Thank you, Charan.